PTA alone can obviously restore flow and get perfusion down to a wound, which is helpful. The main limitation that we've seen in many series is that PTA's primary patency simply doesn't last. I once published a series of 1,000 interventions in which our primary patency for PTA in the tibial location was under 50%. It was between 30 and 50%. So primary patency alone is one issue. PTA also does not deal with the mechanical issues such as recoil or dissections, and that is where stents can come into play. Certainly we have stents for above the knee. Prior to the LIFE-BTK trial, we really did not have anything below the knee, although one could use DES or drug-eluting coronary stents off-label in the tibials, and that could solve that problem. So there you have the scaffolding to deal with the recoil and dissections. You also will have the drug elution to help prevent restenosis, and they do work. The problem is that they do limit options down the road. And so anytime you're leaving a metallic implant in a vessel, you're going to be potentially dealing with that metallic implant should you need to retreat that patient or that lesion, that vessel, or if you need to do a bypass. So obviously surgical bypass is still our last line of defense over preventing limb loss. And when you have a permanent implant in the tibial vessel that you're treating, that's potentially going to limit your ability to bypass that vessel. So the LIFE-BTK trial showed that a DRS device, a drug-eluting resorbable scaffold, has those benefits that a coronary DES used off-label in the tibials can offer. The mechanical scaffolding, the dealing with the recoil and dissections, plus it has the anti-restenosis therapy. But the important difference is that it does not stick around. It resorbs over time, leaving a potentially healthy, healed vessel. So not only does it refrain from leaving a permanent implant that limits your options, it even potentially could expand your options. If you have a area that was scaffolded 2-3 years earlier that is now resorbed and you need to do a bypass, you could even potentially bypass in the area that the scaffold was placed. So an area of a prior occlusion that now is potentially a healthy enough vessel for a distal bypass target.